Hi, everyone. Welcome to today's panel. This is the last panel of today's section of the conference. Our panel today is titled Ethics in AI and Preventing Bias in Healthcare and Diagnosis. My name is Emily Lindemer. I'm the Director of Data Science and Analytics at Wellframe. I also just created the coursework for one of the courses in the newly released AI for Healthcare Nano Degree program that Udacity just launched today. And I'm going to be moderating today's panel. So joining me today is Alex Ermolive. He's the Director of AI at Change Healthcare. We have Tiffany Deng, who is the lead for responsible AI at Google. And we have Jochen Kuhm, who is the CEO of Prevent. I'm really excited for today's panel. We're going to discuss how AI is a powerful predictive technology that can be extremely helpful in diagnosing illnesses and recommending treatment. However, if the technology is built with inherent human biases, of course, the patient's outcomes can be negatively impacted. We're going to discuss how to remove bias in AI and machine learning to help improve patient care. So without further ado, let's jump in. I've prepared some questions for each of our panelists ahead of time. At the end, I'm going to take some questions that have come in through Twitter. So my first question is for Jochen. Jochen, last October, there was an article that was published in Science magazine that made some really big waves in the healthcare industry. The article dissected a widely used algorithm that's used to manage population health, and it found that there was significant racial bias in the way that it determined how sick an individual was. The authors of this paper concluded that this was because the algorithm was based on healthcare spending, which may be very low for very sick people if they don't have access to healthcare or if they lack trust in the healthcare system. So my question for you is, what sort of data was overlooked by the creators of this algorithm that led to this bias, and how can we avoid it in the future?
Yeah, so I found the paper, of course, interesting and incredibly important. On one level, it shows that the algorithm or the AI is performing very, very well, but what it delivers into healthcare is biased and in some way ineffective. And so one of the problems is that there is a single input, and it might not be the best one. Arguably, the input here was, was a data set that's collected primarily from payers and insurers. So we're lacking a lot of information from the healthcare providers themselves. So I would argue when you build these models, you need to make sure you access the right information and all of it. Likewise, the outcome that you were training on was healthcare expenditure. And again, I would ask, and I'm prepared to discuss this, that healthcare expenditure is not the best way to decide on the actual healthcare delivered. And the outcome in this one was very clear that African Americans in this case got effectively worse healthcare. So I think there are two basic things that I take away from that very quickly. One is data. You need to have multiple inputs and the right endpoints. Essentially, you have to ask yourself, is what you train on, the marker, actually what you want to train on? Often the problem. And methodologically, I think there are many people working on this, and I think it's a hopeful sign that our neural network architectures are becoming more adaptable. So in this instance, for instance, why wouldn't you take in healthcare data, patient record data, and payer and insurance data at the same time? Because the capability is being built. So perhaps on a practical level, don't just log into Keras or whatever your favorite platform is and take a model off the rack and make it fit, right? I mean, think about what you're trying to achieve. Those are my take-home messages from this. Quite apart from the fact that it's interesting that it's been well known that certain parts of the population are much less likely to see a doctor than others for many, many reasons. And so since that's widely known, when you build a model, you should take it into account. I have more to say on that, but for now.
Well, one question to follow up with that, Jochen, is do you have a sense of how common it is that we are basing algorithms on, payer only data and healthcare spending, to your point about this not being the best marker? Do you think that this is something that's happening often, or are people more and more pulling in provider data as well?
I want to give a short answer to that. It depends on where you are. And so, for instance, there are outside limitations. I mean, privacy issues, data ownership issues, policy issues that, particularly in the United States, make it very difficult to sort of build the kind of model you would want to build to deliver the best service. That's not to say that it's not, the FDA and other agencies shouldn't have a good look at what we're doing. But I'm looking at other countries or other healthcare systems, some of them in Scandinavia and some of them in Europe, where it is a little bit easier to integrate across these. But nobody's perfect, and the rules are changing all the time. We have a project where we started 6 months and legislation has changed since then. That's in Finland. Sorry. So it's maybe we should have a policy wonk on this panel as well.
I'm gonna come back to this idea of boundaries back to you in a few minutes, Jochen. I wanted to direct a question actually just from that, based on your comments about how in this paper specifically there was this bias in underserved communities. I had a question for Tiffany. So following from that, Tiffany, do you think that AI failed specifically in detecting how hard the COVID minority communities were going to be hit? And what did the data tell us about that? Okay, it looks like we may have lost Tiffany on this call. So I'll come back to that question if we can get her back in. And Alex, I'm gonna jump over to you in that case. So Alex, you have a pretty varied background in AI. So Jochen just spoke a little bit about some specific examples of bias in healthcare. But in general, I was wondering if you could comment on what are some of the biggest challenges in building AI solutions without inherent bias, just in general, and how we can develop AI solutions that don't have built-in bias, even generalizing beyond healthcare.
Yeah, thank you, Emily. So if we go back to definition, what is AI, what is ML, specifically what's machine learning? Machine learning is basically a pattern recognition technique, which is good at detecting patterns from data in order to predict or detect something in the future. Now, this is patterns from data. What if the data is wrong? What if the data is biased? Well, bias is a pattern. AI is good at finding patterns. It's going to find a pattern and replicate it. That's what AI is for, right? So it is up to us, up to the community, to first understand where the bias is, find the problem with data, and then find a way to correct for this problem. So if you think about where machine learning has been used in the past, in the recent history, in most cases, machine learning has been adopted in cases where either the cost of mistake is low, or you're simply tweaking existing processes. So like web ads is a very good example where the cost of mistake is not very high and you're basically tweaking something. Healthcare is not. Healthcare is very different. You're changing people's life. You're making very important decision. So in order to apply AI to healthcare, we have to get the ethics right. Otherwise, it's not going to be adopted at all. But the challenges are that the bias can come from multiple directions. Some of it is data, which you already mentioned. Some of it is the way you build algorithms. So if you don't do it carefully, if your data is, let's say, unbalanced between different groups or something like that, you might produce results which are not working equally well on different groups. And then your prediction or your detection is going to not work equally well for everybody. So that's a very important decision. Another problem that you have with healthcare specifically is that the bias is already in place, is already in data. So in many cases, AI did not invent anything, even this paper in Nature. The problem did not was not created by AI. The problem was there to begin with, right? And if the problem is already in place, so the question is, what is the responsibility of data scientists? What's the responsibility for our community to fix the problems which already exist in the healthcare system we have in the United States? So that's a big challenge.
That's great. Thank you, Alex. I'm going to go a little off script and ask both of you guys, because I think you both kind of touched on it, this notion of kind of policy. I've heard some ideas thrown out there about setting up external parties to kind of monitor the ethics of AI and making sure that there's some kind of checks on algorithms that go out there, because even with the best intentioned data scientists, I think that sometimes, you just can't always think about all of the possible sources of bias. Have either of you two had any experience with kind of trying to implement those sort of external parties to check for bias and kind of instill some policy in algorithm development?
Yeah, I have a little bit of a experience. So yes, so the bias often comes from data, but it's often missed by the data scientist. It's very important for data scientists not to miss the bias. And in many cases, we miss it because we don't think very carefully, or we might think something is not very important. And when we decide what's important or not, we're bringing our own bias into the decision process. So by neglecting to investigate particular issue, or avoiding the problem, or failing to fix it. So yes, it's very important. One of the best practices many companies have is have an escalation path, where every time data scientists have a problem or like unclear situation, and there are many unclear situations in healthcare. It's not just one. There are like a lot of the issues that can be not obvious. That there is an escalation path, so data scientists can very quickly engage particular group over email, which has a variety of people, some probably from legal deployment, some from data science community, which can kind of basically discuss the situation and say, did you look at this? Did you check at that? Did you compensate it with something else? And it's kind of surprising, but a lot of issues can be solved by having this kind of semi-informal escalation path.
Yeah, Alex, I totally agree, actually. And having worked a little bit in building clinical applications, I think we could benefit from a framework such as when you design a clinical trial, there's a review, which anytime you do even write a grant to NIH, right? Is it ethnically diverse, etc.? There are some bullet points. Is it gender balanced, etc.? So I think, personally, I think we could benefit from having a checklist, like a framework, sort of like when the pilot gets ready to start your plane, right? We would do well with that, or even having a review agency that approves particular applications. I think I want to echo something that I heard in a seminar at the Human Artificial Intelligence group from Stanford, which is basically legislation or supervision is going to be really, really hard, right? I mean, and in the absence of sort of an absolute moral authority, also kind of difficult to implement, like what's the ethically correct way of building an algorithm is going to be tricky, I think. So I want to raise that issue. Maybe that is what will end up happening, but
yeah, the legal framework is almost impossible to implement because, for example, when you say privacy, is privacy important or not? Well, it is important until it's not, and it's different to different people. Some people think it's more important, some people it's less. It's less important, it's maybe more important on a normal, days, maybe becoming less important when we have a pandemic or something like that. So even the same issue, which we kind of all agree is valuable, what is the value and how the value changes over time might be quite dramatic from day to day or from month to month. So writing one legal framework becomes almost impossible. So I think it has to be done through ethical, discussions, ethical considerations, and some kind of process to deal with complex ethics issues.
That's great. Thank you both. Well, I'm sure there's a lot of really smart people in the audience today, so maybe we have some people that will start thinking about that and make some progress. I want to give Tiffany a chance to jump back in. Tiffany, are you able to connect with us?
I am, yes. Apologies for all of the technical difficulties, but I have arrived. I made it, finally.
Great to have you here, Tiffany. Tiffany, I have a question for you that actually follows from this kind of discussion of privacy that Alex just brought up. Since you have career experience both in bias and machine learning as well as privacy issues, I was wondering if you could tell us what some of the biggest concerns are about patient privacy and ethics that prevent us from advancing AI in healthcare.
Sure. I mean, we've talked a lot about data, and I think that's one of the biggest issues, right? Is that there are a lot of folks that have, a deep distrust with the healthcare, community. Some of it is really rooted in historical context when you think of Henrietta Lacks or the Tuskegee experiment, right? Like this very deep, entrenched kind of fear of their privacy being invaded, or their personal attributes and information being shared without their consent. And I just read something that said 3 in 5 Americans who are unable or unwilling to use an app for contact tracing, right? So there's this really deep distrust that folks have with their personal information, and rightfully so. And so I think that this distrust really leads to the gaps in data, perhaps less participation in trials. And so there needs to be more transparency and a more robust conversation around how data will be used. And I think the ethical considerations and frameworks and patient consent that we have to ensure is being developed while we're kind of thinking through and developing these technological breakthroughs. And I think that once some of that is in place, I think it will give people that peace of mind that, through the advancement of AI, as it becomes more ubiquitous, they can have trust in the transparency, how their data is being used. And that can really lead to more breakthroughs.
Yeah, that's great, Tiffany. It definitely sounds like there's somewhat of kind of a feedback loop here. We have to make people trust AI before they'll give us the data to make better AI, et cetera. So it's a hard problem to solve, but I think that's some great insights. I had a question for you before, Tiffany, so I'm also going to come back to that now and ask it to you now. So at the beginning of our talk, we had talked kind of about how there had been this negative impact on minority communities with, these general healthcare algorithms. I was wondering if you could comment on whether you think that AI failed in detecting how hard COVID specifically would hit minority communities and what the data told us there. I think it probably ties into some of what you just said as well, with this mistrust by some groups of individuals in the community.
Yeah, I think so. I think it's a great tie-in. But I really think what this virus did was it really kind of shed light on the really deep fissures in our society, right? The social determinants of health in minority communities that are just really fundamentally lacking in so many areas, right? So when you think about minorities, a lot of times they tend to live in more densely populated cities, right? Densely populated areas. Oftentimes they're very segregated, when you look at the likelihood that they'll have to use public transportation, which is another area for transmission, right? With this disease, and traverse the whole entire city just to maybe get to their place of work. And then you think about, they're more likely to have these really chronic illnesses, these underlying illnesses that are caused due to things like food deserts or poor health outcomes, and an inability to pay for their medications, right? So they're already in a poor and more fragile healthcare state. And then you think about the fact that they're probably less likely to visit a doctor for fear of the cost. They don't have health insurance, perhaps. Their immigration status, they may be afraid and distrustful to go to the hospital because of those reasons, right? And they may come in later in kind of the cycle of COVID, where they're very sick, right? And so taken all together, right, those things really do have a disproportionate effect for the survival rate of this disease. And I think, again, this is an opportunity for us to really examine what the data is telling us and how we really need to build some of the really fundamental social foundations for our society to ensure that outcomes are more equitable, that people have access to healthcare and access to education and access to jobs within their communities. And if all of those things are equal, we'll be much better prepared to combat a pandemic in the future.
Great, thank you, Tiffany. Jochen, on this note of talking about, bias and, different minority communities, clearly that differs across the globe, and we're dealing with a global pandemic right now. You have a lot of experience in, working in different parts of the globe, particularly Scandinavia and Europe, as you had just mentioned. I was wondering if you could speak to how you think bias in healthcare differs across the globe, and how this might show differences on how COVID impacted different countries.
Yeah, so it's obviously a difficult question to answer completely. But what strikes me is that, what's often overlooked in the models is human behavior, or even the culture, right? And so I think we tend to overlook that and pretend it doesn't exist. And this is particularly difficult. I also used to work in Africa, and so it turned out that actually one of the most interesting pieces of information that people should look at is there's a professor at Stanford, Chris Sita, whose group has done some interesting work in predicting outbreaks of malaria, incorporating cultural and climatic and historical factors. Interestingly enough, they have been able to improve the prediction power simply by looking at the history of a community and a population. So I think on one level, we need to start acknowledging that these are big players. Just like in COVID-19 right now, the way people behave and whether they trust, whether or not you comply with social isolation depends on whether you trust the person who tells you that message, right? But the other thing is also, I feel like in the United States, there is sort of a tacit but also explicit notion that healthcare data belongs to the physician and the hospital, not to you. This is probably worse for ethnic minorities. And so perhaps we need to ask some deep questions as to how do we deal with this information? And if it truly belongs to the hospital, does that make the hospital responsible for taking the right steps or making things, explaining things? We have consent forms for participating in most things. And yeah, I think, perhaps a long-winded answer, but I think there are some big problems, and we could, once we identify who might be responsible, at least we can task them with thinking about that. I don't know what you think, Tiffany, but I would love to hear your opinion on that. Or Alex, not neither.
Yeah, no, I totally agree with that sentiment. I would just hearken back to, kind of the previous question, that, we really do need to seriously think about the ethical frameworks, right? And really building up that trust with different communities, because that is the way that we will be able to advance healthcare, but also advance AI, I think.
Yeah, thank you both. I think we could have a whole nother panel kind of on data ownership and how this affects a lot of what we're talking about right now. So that's really good food for thought. Alex, you had kind of mentioned, the AI wasn't biased, the bias was already in the data. And I want to come back to that statement that you made, because I think it's really important. And you said, it's really data scientists' jobs to be responsible and to notice that exists before they even build the algorithm. And I was wondering if you could kind of shed some light on some ways that we could remove bias from the data inputs themselves while still maintaining integrity of data.
Yeah, I think this is a very important question, and why data scientists are responsible for this is also very important. Because on one hand, we know what bias is in general, and on the other hand, as soon as you start applying it to your particular use case, you're going to find that your set of steps is actually quite a bit different. Depends on what use case. Bias is always a use case specific. Sometimes it's you care about group bias, sometimes it's personal fairness, sometimes you care for one parameter or another parameter. So bias is always use case specific, and like it's very difficult to give one set prescriptions, but there are kind of some ways to kind of articulate what to think about. For example, in many cases, what people do, the first things people do, data scientists do, when they get a question of bias is simply remove the feature, remove the race, remove the sex, remove the whatever sexual orientation or religion, whatever. The problem is you're not removing the bias. You're only removing your ability to see the bias, but the bias is there, and the AI will learn it from other ways, like through names or through zip codes. Or there are so many ways AI can get back to the bias that like removing the indicator does not really work. What you need to think about is something completely different. What you probably want to think about is how do you compensate for this? In some cases, you can accomplish these results but by rebalancing the data set, making sure you have an appropriate number of people represented different groups, for example. In some cases, you need to basically change, like your objective function. So you might actually skew your results based on some goals that you might have. And there are some cases where people might say, okay, I don't want to do that. I just want to add something. In my model, once the result is there, I'm going to basically add, $1,000, whatever, for the model output, and just kind of fake your results if you cannot fix it within the model itself. But yeah, and generally, you have to look at all three places. You have to look at the data where you're getting into, as that given to you. Trying to figure out if it's biased or it's accurate. And there are actually tools for that. So the industry is actually responding to the needs. The most famous tool set is the one from the University of Chicago for the data bias. But the Google has a tool set, IBM has a tool set. I'm probably missing a bunch of other companies working on that. So there are some very simple and very effective tools which allow you to find a bias of data or lack of balance in data. Then you need to make sure when you're training the data, your objective function or the way you train the data helps you to eliminate whatever issues there might be. And finally, it's also important to remember, even once the data science is done and the model gets implemented, it's possible to introduce bias at that point. If you train model on one data set and you implement it for another purpose and you apply it to different people, your results might actually be biased in that as well. So it's important for data science to make sure that, to know how the model is going to be used and what kind of decisions will be made based on the model output.
That's great. Thanks, Alex. Just to open it up to all panelists, one question I had, I think, between the three of you, there's quite a lot of experience working with lots of different data sets. And we've touched on how, single inputs are bad and you need to look at things like social determinants of health, Tiffany brought up, even climate, Jochen brought up. Are there any recommendations that you guys have about kind of using open source data sets creatively to look at healthcare in different ways, kind of, outside of the box that you might always think about, like payer data or EMR data, that you could kind of share with the audience?
Well, I can make a stab at it, but only, of course, from my perspective, right? I mean, there are a bunch of open data sets that are available. Some of them are very, very good and exhaustive. I used to work in genomics, and I still do. So there are some data sets out there, starting with the 1,000 Genome Project and then the 100,000 UK. etc. I think it's promising that there is an open data initiative that Microsoft is now supporting. Whether or not it's relevant to all questions is an open question, but yeah, I mean, in the work that they did in malaria prediction, they found that census data and weather data that were widely available were super useful. So that, in my experience, there's a tremendous amount of data out there, including like satellite images that tell you, let you examine the Earth with a 10 square meter resolution. But it's incredibly hard to get, right? I mean, and I think I heard that from you, Alex, that then you have to sift through it and spend effort and resources on data scientists to help you integrate it. So, I mean, if
there is also an interesting project from the government, and the project called All-in-One. It was, All of Us. And that's a project that was launched by Obama administration. And what they do is they try to bring all of the data in for a particular person together. And the problem is you need to have all of the data. So it's healthcare records, it's your lifestyle, genetic. Right now, the data does not exist in one place. It might exist in 10 different places. And plus you need to aggregate it across very large population in order to make this data useful. So the goal for this project, All of Us, was to get complete data set for 10 million people. Last year they had like 100,000, which is already good, but it's all volunteer based, so people can contribute their own data to that particular data set. But once the data set becomes big enough, it becomes very valuable research tool for researchers to try to correlate, let's say, disease progression with genetic data, which is actually very hard today because the data just does not exist in one place.
That's a great point. Thank you, Alex. Tiffany, did you have anything that you wanted to add to this idea of looking for data kind of outside the box and open source places you could get it?
Yeah, I would just, the spin that I would add on this, I agree with both panelists. I would just say that it is important when you're looking at open source data sets that to keep in mind that it's very hard to kludge together, right? A data set that is like fair and representative. There's a ton of cleaning that you have to do, right? There's just a ton of inputs and effort that goes into making it useful. And it's also important to keep in mind how that data was collected. I think that's a key point. Was, there the proper consent? How, was it labeled, right? Like thinking through all the ways that bias can exist within that data set, and thinking about the trade-offs that you'll make before you use that data within your model is very important. So keeping all those things top of mind, the ethics, as well as the consent piece and the diversity and representativeness of a data set is super important and is really predictive of the outcome that you'll get and that you'll receive from your model.
Great, thank you guys. So this is a perfect time, I think, to transition to some of our audience questions that have come in through Twitter. I'm gonna take probably about 3 of them. We have about 10 minutes left. So the first question I'll pose to Alex. Alex, in using AI, how can we better understand the impact of understaffed and unequipped hospitals and the effects on the treatment of sick but non-COVID patients?
Yeah, it's an interesting question. So AI is in general working with historical data. So we're better at finding, patterns in historical data than doing real-time response. So the data has to come from somewhere. So if the hospital is overwhelmed or understaffed in response to the COVID, the question is what data, the first question for AI person would be where the data, right? What data set we have. There are some people who do epidemic tracking using social media data. So they don't require you to have a full data set from the hospital itself, but what they do is basically tracking the epidemic. If a particular township has a larger mention of what pneumonia, for example, in social media, then they're likely they're hit by epidemic more than other places. So those type of tools exist. There are some people who are doing good job. There is a startup called Blue Dot. There is Carnegie Mellon Flu Epidemic Project. There is Boston Children's Hospital. So several projects exist to track epidemic. So the point of this is you can use external data before, like, you know, you can use this data in order to make prediction where the impact of COVID is going to come before the impact actually comes, you know, and overwhelms the hospital. But in order to do that, you kind of have to do, in order to be predictive, you have to use the data which hospital doesn't have yet, right? So this is the challenge.
Right. Jochen, do you have anything you want to add, since that was an audience question?
Yeah, it is an incredibly hard problem to deal with something that you have never seen before. So I mean, the interesting story about COVID that I recall is that it turns out that COVID patients are unusual in that they can have very low blood oxygen and still be functional, which we have never seen before, right? This may not be an AI problem alone, but usually AI is terrible at dealing with patterns that it hasn't seen before. So I've been thinking about this for a little while, like what should an artificial intelligence do when it encounters something that doesn't fit its worldview? This is probably not one of those expert systems that we're used to today, but people are starting to think about that. So I think, okay, in short term, not an easy solution, other than outliers shouldn't be thrown away, but should be incorporated into the system.
Great. I think complicated, but very great question from the audience. So thank you for that. Tiffany, I have a question here kind of about responsible use of data from the audience. So I will pitch it to you first. The question is, at this time, there are many reports that certain ethnicities are dying at faster rates, which can be attributed to access to healthcare, pre-existing unequal healthcare treatment, and poor health habits. How can someone responsibly use the data and AI to make reasonable predictions?
Yeah, that's a great question. So I think that in order to make good predictions, I think it's just important to really delve deeply into those social determinants of health, right? And keep an open mind and understand that, like, it's fundamentally unbalanced and needs to be changed. And there's so much nuance involved from, you know, minority group to minority group around why these fissures exist. So keeping that in mind is super important, right? You have to understand the nuances involved and, you know, why the Native American population will look different than the African American population that might look different than the Hispanic population, right? And on and on and on. And taking into account those specific nuances and not lumping everybody and aggregating everybody into this, you know, big monolithic group, which is hard to do with AI, and it's hard to do with bad data, as we've kind of like pounded home over and over and over again this afternoon. But keeping all of those things in mind, all of those nuances, and also all of the kind of societal issues that are swirling around some of these things. I think putting all of that information together can help improve kind of the outcomes and the predictions for models as they're looking to really uncover and unpack the reasons why COVID is affecting minority groups, you know, is more deadly in minority groups than others.
Thanks, Tiffany. I'm going to end with one question that I think I'll go around and ask the three of you, and it's from the audience, and is sort of hopefully ending on a positive note. Have you guys seen positive change in AI, particularly in helping underserved communities, which is one of the things we've been really focused on in this panel? And if so, do you have any examples that you can give? Alex, I'll start with you.
We actually have a project in the space where we help sign up people So in the United States, people who live below poverty levels, who are older, are eligible for both Medicare and Medicaid. Many of them don't take advantage of the programs they're already entitled to, and therefore their healthcare costs can be overwhelming, and some have to declare bankruptcy because Medicare doesn't cover everything. So we have a project where we actually target people who are not taking advantage of the programs available to them in order to help them with a financial help them to get enrolled in order to reduce the financial burden of the healthcare services for elderly population who live below poverty level. That project already exists. It's out there. We're working with different insurance companies to get it implemented.
Great. Thank you, Alex. Jochen.
Yeah, I mean, I'm actually an enthusiast. I think it can make a big difference, especially in healthcare, where I'm working. I'm thinking particularly of one of my StartX cohort companies, Lark, that provides AI support for essentially AI nurses in hospitals that help people comply, take medications, basically help deal with the patients in the hospital. They are finding that this is a wonderful and powerful tool, especially in a time of crisis where you may not have enough nurses. So very hands-on, very seemingly simple, but incredibly difficult to implement. And the other aspect of most AI applications that I really like is that they tend to democratize healthcare a little bit, because experts are expensive and sometimes not very close to where you are located. And artificial intelligence can be made available to everybody across the country, even in fairly remote locations. And so I think those are some big benefits that we can bring. It would be better if we keep the ethics in mind and make sure that we really make this available in a fair and equitable way. And, coming back all the way to the beginning of bias in treatment when it's ruled by AI.
Great, thanks,
do it right. Sorry.
Yeah, and Tiffany, do you have any kind of final closing thoughts about, positive directions you've seen AI trending, particularly through the lens of underserved communities and healthcare?
Yeah, so I've been inspired. I don't have a specific example, but I've been inspired by all of the energy from young people, right, around this pandemic, wanting to find solutions, being curious about how they can get involved in AI, understanding how this is deeply affecting just us kind of as a community, a global community. And so I have gained so much inspiration by reading stories about people thinking about, 15 and 16-year-old people thinking about how they can create apps, thinking about how they can really help their neighbors, thinking about how they can get them food and medications. I think those are the people that we should be thinking about and helping to kind of cultivate that curiosity and that drive, and that inspires me.
Great. Thank you for ending us on that very positive note, Tiffany. I completely agree. I think there's so much good momentum out there right now. So I think this is a great place to stop. I wanted to thank all of our panelists for joining me today. It's been an honor to be on a panel with such smart and diversely experienced people. So I hope that, the audience was excited, and thank you also for attending. This concludes the first day of the AI for Healthcare virtual conference. Please join us tomorrow at 9 a.m. Pacific time, where university founder Sebastian Thrun will interview Dr. Eric Topol. Dr. Topol is the EVP of Scripps Research Institute and the most influential physician leader in the US. He wrote a book last year called Deep Medicine. My data science team at Wellframe and I actually read it as part of our journal club. I would highly recommend checking it out. It is very relevant to this conference. Also, please visit Udacity to check out the AI for Healthcare Nano Degree program that just launched today. Thank you, everybody, and we will see you tomorrow.
Thank you.
So much fun. Thank you.